Good morning, everyone. My name is Ahmed Samir. I am a lecturer of radiodiagnosis and intervention in Alexandria University Faculty of Medicine, Egypt, and a consultant of chest imaging. I am pleased to introduce myself and to start a series of chest CT cases review. And I will start today by part 1, 9 cases of chest infection. Case number 1. Of course, this is the lung window. We will review the case first. Of course, as everyone notices, there is multiple consolidative patches are seen in both lung fields. These multiple consolidative patches are mainly characterized by this important sign, which is called air bronchogram. Air bronchogram, smooth, non-interrupted internal bronchial tree passing through these consolidative patches without any interruption or stenosis or amputation of its lumen. This means this is an alveolar pathology, not an endobronchial or peribronchial pathology. That's why we consider the pneumonia or pneumonic patches in the first consideration or first diagnosis for us. Sometimes there is a ground glass halo around this pneumonia, representing element of alveolitis or reaction of the alveolar system around this consolidation or infection. These linear bands are called coarse atelectatic plates. Coarse atelectatic plates because they are thick. And the consolidation also may take triangular shape. This means that this consolidation is accompanied by atelectasis. It's called consolidation atelectasis, and it represents either actual infection, actual true recent infection, or maybe a sequel of previous infection or old infection. So this consolidation with the smooth air bronchogram is typical for pneumonic patches. Bacterial pneumonia, yes. If you go to the mediastinal window, you can find some reactive looking lymph nodes, prevascular lymph node anterior to the superior vena cava, pretracheal lymph nodes anterior to the carina, maybe carinal lymph nodes, shotty prevascular lymph node anterior to the aortic arch, and shotty supraclavicular lymph node as well. Case number 2. We start first by the lung window again. By the way, this is what's called the azygous fissure, the site of crossing of the azygous vein towards the superior vena cava. And there are small pneumatocyl at the first of the case. The main pathology here is what's called ground glass opacity or ground glass patch. We mean by the ground glass patch or opacity, it is white part of the lung, which is characterized by being so clear that you can see through which the traversing vessels, it's not obscuring the traversing vessels as in cases of consolidations. Also with smooth air bronchogram inside it. It is smooth and homogeneous without any septal thickening, without any areas of air trapping, and of course it's mainly peripheral and subpleural located. If you go downward, you can find another small patch here, subfissural, and you have to train yourself to get these small patches because it could be the isolated finding in the case. Also, medial and basal there is a small lesion, and lateral left basal there is a small subpleural pathology as well, subpleural patch, ground glass patch. These are classic signs for the current atypical viral pneumonia, COVID pneumonia. These also are atelectatic plates. Again, there are few pretracheal and retrocaval nodes. Case number 3. Again, the main pathology here is the subpleural ground glass opacities, subpleural ground glass patches in these patients. It's also atypical viral pneumonia, COVID pneumonia. Scattered subpleural in both upper and lower lung fields, anterior to the fissure and posterior to the fissure, respectively. But here I want you to notice this sign. It's a very important sign here. This is what's called curvilinear bands. Curvilinear bands are atelectatic bands as well, or fibrotic bands as well, which are present but not perpendicular to the pleural surface. It is parallel to the pleural surface. It actually presents a previous opacity which was here, and there was healing of the most eccentric and subpleural parts. Now it is apparent as a subpleural sparing, while there is fibrosis and consolidation of the internal eccentric part of this lesion. These curvilinear bands mean this is a healing stage of this COVID pneumonia. So in your report you should report that this patient has partly healing atypical viral pneumonia, partly healing COVID pneumonia. Again, you can find lymph nodes, pretracheal lymph nodes, pretracheal retrocaval lymph nodes. This is a left paratracheal lymph nodes. Never to say it is a aortopulmonary node, because if you can take an axis like that, passing by the ascending thoracic aorta and descending thoracic aorta, and you find this node left on the right side, to which this is a left paratracheal node. If you find it on the left side, it would be an aortopulmonary node. Again, pretracheal nodes. Case number 4. This patient has classic history of being an IV drug abuser or IV addict. By the way, the same pathology can be described to as infective endocarditis patients. As you notice, there is variable sized, mainly peripheral located, cavitary lung lesions, coupled with few small, still solid lung lesions. The main presentation is usually by these cavitary lesions actually, and the presence of other solid lesions is not typical in such case, but it could be seen, it could happen. That's why you have to see this. With this history, these typical benign lung abscesses are called septic emboli. Septic emboli actually It is emboli because this is pulmonary showers, but it harbors the microbial organisms towards the pulmonary circulations, then towards the lung, causing these infarctions which are septic, infected. Each of which, as you see here, has classic finding which is called feeding vessel sign. Feeding vessel sign is it's a feeding vessel which supply this. You can be reached towards this lesion. You can trace a vessel reaching this pathology. I need you to notice here this finding as well. This is a subpleural wedge-shaped pathology with central ground glass opacity and peripheral organizing material. This is what's called Attell sign. This Attell sign in a subpleural location, wedge-shaped appearance in such patients, the most important and the first prime diagnosis will be for pulmonary infarctions. So the Attell sign here represents an infarction actually. Attell sign was first described with cryptogenic organizing pneumonias and now with COVID pneumonias, but it could be seen with other differential diagnoses, one of which is pulmonary infarctions. Case number 5. Of course, this is classic typical sign of bronchiectasis, cystic bronchiectatic changes, which are usually connected to the bronchial tree, cystic in shape, circular in shape, with airflow leveling denoting recent infection on top, and retained fluid secretions. What about this pathology? You may misdiagnose this as a mass actually in the first, but if you notice very well that it attains a tubular configuration, parallel tubular configuration with a hypoattenuated material inside it. So it is actually a dilated bronchial wall, but with retained hypoattenuated material or mucus fluid. This is called typical what's called mucus plugging. Of course, it could be associated with some sort of consolidation and atelectasis. You can see these tiny calcific foci here and here, represented old bronchioliths or chronic standing process. Also, this classic fissure respecting sign means this is a benign process, it's not a malignant process. There is no transfissural fixation, it is mostly respecting the fissure and respecting the pleural surface. Case number 6. Yes, of course, the main pathology here is apical located. It's fibrotic bands, as you see, fibrotic changes, accompanied by cystic changes, maybe cystic bronchiectasis as well, maybe traction bronchiectatic changes as well. As you see here, they are reaching the fissural space, maybe accompanied by areas of air trapping. This typical location of apical fibrocystic changes or fibrocavitary changes is typical for all TB, insult all TB infection. Yes, apical fibrosis with cystic changes and traction bronchiectatic changes denoting chronic process, inactive process, mainly of alt TB. If you have this consolidation, you should consider the presence of what's called scar carcinoma. It is a complication of alt TB, but when to suspect scar carcinoma, actually, on basis of CT, you can suspect scar carcinoma only if you have serial studies and you have progression size of this consolidative patch, or if you have obliteration of the extrapleural fat plane or invasion of the overlying ribs. Can you rely upon the speculations here? No, the presence of speculation is classic because of the fibrosis itself. So, if I have progression its size or direct signs of invasion, I will suspect scar carcinoma and ask for PET-CT or MRI. Case number 7. Again, if you can notice, there is bilateral apical fibrotic changes, followed by this cavitary lesion in the posterior segments of the right upper lung loop, showing smooth wall and minimal airflow leveling, nearby consolidative changes and small nodules. These nodules below attaining the typical tree-impulse configuration, centrilobular tree-impulse configuration, representing endobronchial pathology, like the inverted Y shape or Mercedes sign. This means that I have a cavity and bronchiolitis as well. Of course, I have to suspect bacterial infection with gas-forming organism, but if you look carefully for the presence of the apical fibrotic changes, you may think of an alt TB. Also, the location of this cavity in the most lower part of the right upper loop, in the mid-zone actually of the lung, you have to suspect what's called reactivation of alt TB. As you know, there is two signs for reactivation of alt TB. One of them is specific, which is presence of a cavity, and the other one is non-specific and could happen with any endobronchiolitis, like the tree-impulse nodules. You can search for any calcific nodules in the lung or calcific lymph nodes. There is no calcific lymph nodes actually, but there is this calcific pleural nodule, which is also autogranulomatous and suspicious for alt TB. Case number 8. Obviously, this patient is known for lung emphysema, centrilobular, mixed centrilobular and paraseptal emphysema, and we have this classic pathology. This is a lung nodule, cavitating lung nodule with the eccentric cavity. It's called an eccentric sign or eccentric air sign. This eccentric air is classic for fungal infection, non-invasive fungal infection, which is called mycetoma ball. Case number 9. This patient is a leukemic patient. Apparently we have bilateral diffuse ground glass opacities with smooth septal thickening. First of all, its diffuse lung pathology, areas of air trapping above. You can first consider the presence of pulmonary edema or pulmonary congestion, but the absence of subpleural sparing and also the inhomogeneity of this ground glass material and presence of internal sparing as well make you concern the presence of alveolar hemorrhage. There are several pulmonary nodules, as you see. These several nodules containing a solid part actually and a peripheral ground glass part, which is called peripheral ground glass halo. This halo sign is typical for invasive pattern of infection, fungal infections called invasive aspergillosis. Of course, here you cannot differentiate actually between the invasive aspergillosis and relapse of leukemic infiltrations. Before 2010, the classic halo sign was described for the invasive aspergillosis, and after 2010 it was described also for the presence of relapse or leukemic infiltration. Of course, here the clinical and laboratory correlation is mandatory. Actually, this was the last case. I hope you enjoyed our cases about chest infection, and I hope the next lectures will be useful and informative as well. Thank you very much, and thank you for your listening. Thank you. Hope to meet you again.